Hi everyone, I'm going to talk about dermatitis in pregnancy as part of our CREOG preparation video project. Much of this information can be found in the ACOG article titled Common Dermatologic Conditions, as well as an article in the contemporary OBGYN journal entitled Dermatoses in Pregnancy. Both of these articles are where most of my resources have come from for this talk. So, first, as we think about skin conditions, it's really important to think about the basic structure of the skin. I think this image is a really great overview of the various different layers and components of skin, kind of a good basic science review to get us oriented. So, as you can see here, we have the epidermis layer, which is really the tough outer layer of the skin, made up of stratus squamous epithelium, and it's also made up of keratinocytes. Then we have the dermis, which is a thick layer of fibrous and elastic tissue. As you can see, this is where your hair follicles are, your sweat glands. It kind of helps with the flexibility and strength of your skin. And then below that, we have the subcutaneous tissue, which is mainly made up of adipose tissue, kind of helps you regulate your body temperature, helps you within the heat and cold, and then also provides some protective padding. Most of the dermatologic conditions that we're going to talk about today are involving the epidermis layer. So, thinking about skin changes in pregnancy, there's kind of three categories that these skin changes kind of fall under. And so, the first one is hormone related benign skin changes. Then we've got skin conditions that were already there before you got pregnant and may change, meaning may worsen or get more intense, or may lessen during pregnancy. And then last, we have things that are more specific to pregnancy, so pregnancy specific skin changes. Some of the things that, I'm not going to focus on here in our talk, but that are things that you may see during pregnancy are things like eczema. So that kind of falls under the pre-existing skin category. You can see things like spider telangiectasias, which can worsen in pregnancy because, as you know, we have increased blood volume, and that can cause increase in the telangiectasias and being able to see them more frequently. We also have things like atopic dermatitis, and then one other thing to consider is psoriasis. And psoriasis is actually more likely to improve in pregnancy than to worsen. But these are some of the things that I'm not going to talk about here today, but are good to at least be aware of and be able to talk with your patients about if they notice worsening or improvement in their skin conditions that were already pre-existing. So, common things being common. This is what, in the general world we call stretch marks. The more scientific word for them is Striae Distensae or Striae Gravidarum. And as you can see here, they're mostly here located on this young lady's belly. They usually develop after about 24 weeks gestation. It's actually kind of multifactorial why they present. Sometimes it can be related to mechanical distension, just with the pregnancy as the skin grows and stretches. It also can be related to hormones. So when you're pregnant, you increase the amount of adrenocortical steroids that you produce, as well as relaxin and estrogen. And these can all affect the skin and cause these marks or striae to develop. There's usually two kind of categories that you think of. So striae rubra, which is when they kind of start out as this red or violaceous color, and then striae alba, which usually presents after the striae rubra, meaning that it usually becomes more of a more skin-toned appearance to the striae. And so in terms of management, people will come into the office and ask, how can I prevent this? How can I treat this? And there's no actual evidence that shows that these creams and emollients and oils actually prevent it. One of the articles did mention topical retinoid therapy, I guess, after pregnancy for people who have striae rubra that is continued. So that's one thing that you can consider. It's also important to know, as I should have mentioned before, with all types of skin conditions, whether you're pregnant or not, it's important to be able to recognize it in various different skin tones. So striae gravidarum is actually more common in women of color. It's important to be able to look at images of all types of skin colors to be able to identify these things and counsel your patients appropriately. So here we have another condition that's more specific to pregnancy. It's called polymorphic eruption of pregnancy. It's also known as pruritic, urticarial, papules, and plaques of pregnancy. So another term would be PUP. So as you can see here, you'll see in the next photo, but this usually kind of happens pretty abruptly. It's usually kind of a rash that occurs around the striae that are already on the belly. It's kind of these plaques that coalesce together, and it can also occur on the buttocks, the trunk, and the thighs. It usually spares the umbilicus, and also spares the palms and soles. And fortunately, this rash is not associated with maternal or fetal morbidity. So the things that I have highlighted here are important to remember as we go forward, because then we can contrast it to some of the other conditions in pregnancy. Here is a photo of PUP. You can see that right at the bottom, you can see that there's kind of these plaques that are coalescing together. And this is a really good example of how they're really present around the striae that have already been there. And it's a good example of how there's really no involvement of the umbilicus. And like I mentioned, that'll be important as we move forward and we compare and contrast. So some of the risk factors for developing this condition are rapid weight gain in pregnancy, multiple gestation in pregnancy, and then nulliparity. One other distinguishing thing between this and one of the next rashes that we're going to discuss is that this rash is a little bit less likely to reoccur in subsequent pregnancies. So moving on, this rash, as you can see, is similar to the other in that it's on the belly. There's plaques that are coalescing, and it's also on the thighs. But as you can see here, there are these tense bullae that you can kind of see more, you're kind of close to the belly button. And it's also important to note that the belly button or umbilicus here is very heavily involved. And so that's one way that you can distinguish it from the rash that we just looked at. And this rash is actually called pemphigoid gestationis. And so we'll learn about that on the next slide. So this rash usually happens in the late second and third trimester. It's actually autoimmune in nature, so it's associated with HLA-DR3 and HLA-DR4. And actually, if you were to do a biopsy of this, then you're more likely to see linear C3 and IgG staining. That's one thing that could be tested and is important to know because it distinguishes it from other rashes where you may see those C3 and IgG staining, but it's more unspecified, so it's not linear. This rash, as I mentioned before, can involve the belly button. It also may involve the palms and soles, which is less likely in the PUP rash that we looked at earlier. And then this rash is actually associated with an increased risk of mothers going on to develop Graves' disease. So if you see this type of rash, it's important to check thyroid function test. It's also important to know that this rash has an increased risk of being associated with hydatidiform moles and choriocarcinoma. So if thinking about how do we treat this, you can treat this with oral antihistamines as well as topical corticosteroids. So the dosing that I read about was 20 to 60 milligrams of prednisone daily. And then once the blisters disappear, then you can kind of taper it down. One thing that I think is also important to know that is able to distinguish this rash is that it can flare up at the time of delivery, and it's more likely to actually reoccur in subsequent pregnancies. So some of the fetal risks to this rash, as I mentioned, with the PUP rash, there were no really fetal or maternal risks associated with that rash. But with this rash, there is an increased risk of intrauterine growth restriction. as well as prematurity. There's also a risk that the baby could be born with mild skin rashes just because there's transfer of the antibodies that causes the skin disease to the baby. And then, as I mentioned on the previous slide, there's an increased risk of Graves' disease for moms, and an increased risk of developing this skin rash in subsequent pregnancies, but oftentimes it presents earlier, and the subsequent pregnancy is also a little bit more severe. So moving on, I know that we're talking about rashes, and when you think of intrahepatic cholestasis of pregnancy, you always think, this isn't associated with a rash, so why are we talking about it here? But I think because it presents with intense pruritus, just like some of the other rashes, it's important to think about, especially because it can have pretty major effects on the fetus if it's not caught and there's not proper monitoring. So this disease is something that is genetically linked and hormone dependent. There's no primary lesion, as I mentioned before, but you may notice skin excoriations on a patient from a significant amount of itching. They usually have itching on the extensor surfaces as well as the palms and soles. And some of the risk factors for developing this are Hep C, when you have high levels of estrogen, so maybe multiple pregnancy, and progesterone. And then there's some genetic component as well. So it's important to check bile acids, liver enzymes whenever you're worried about something like this occurring. One of the other conditions that is less talked about is atopic eruption of pregnancy. And this can present with itching. It can present with kind of this eczema-like rash. And it usually occurs in patients who already have a history of atopic dermatitis, but it could be a new finding. And it's thought to be mediated by T helper cells. It's usually self-limited, and with this rash, fortunately, there's not really any maternal or fetal risk associated with this rash. With this last rash, which is pyogenic granuloma, this is something that can present in pregnancy. It can also be called pregnancy granuloma. It's usually actually a vascular lesion that is made up of multiple capillary hemangiomas, and it's associated with when someone's pregnant and they start to have increasing levels of the hormone, they're more likely to develop this. It can also result from trauma. And so thinking about management of this, if it doesn't go away on its own, some things you can think about are cryotherapy or sclerotherapy. But I think if you don't feel comfortable managing this, it's always okay to refer to dermatology. So I think I mentioned this as we went along, but it's very important to be able to distinguish between the different things that we're seeing. So here's a really good slide. I've already talked about the ways to distinguish these main four conditions, but this is a really good slide to look at if you really want to just hone it in and talk about and look at what's the difference between the two, what are some different ways that these things present that can help me tell the difference, and then how do I treat them. I know that I'm running over time, so I'll leave this slide for everyone to just review on their own, but it's basically just a summary of how to tell things apart and how to treat them. And these are my websites that I used, as I mentioned before, ACOG and Contemporary OBGYN, and then some of the photos that I used.